Thank you so much. It's really a pleasure to be here, and congratulations on a great symposium so far. Looks great. So I was tasked to talk about hepatobiliary outcomes. I do teach longitudinal courses for MIS, HPB, and robotics, but my real disclosures are that I'm not a trauma surgeon, and I probably cause more HPV trauma than I actually treat trauma patients. And also, it's really difficult, as I was thinking about this, to talk about HPV trauma because we tend to talk about hepatic or pancreas or biliary or duodenal by itself, but unfortunately, when you all see these, you're seeing a mishmash of all of them together. And so what I may say is the thing to do about liver may not be true because the pancreas is also injured. And so it's kind of a little bit difficult that way. So instead of talking about specific cases, I want to really talk about how to mentally think about this, and hopefully that will be helpful, and then we can have a discussion. As an HPB surgeon, I also recognize that where I'm helpful is really not in the acute setting. It's sometimes in the acute setting. I do get a lot of calls, hey, I'm in the OR and this is happening. But really where it becomes really helpful is in the delayed setting. So we'll talk about that. And the key here is to basically, in the end, have a good outcome, longitudinal outcome. So hopefully that'll be our discussion. I want to briefly talk about terminology. Not that you all don't know this, but it's just important to understand the consequences, the long-term consequences of HPBD trauma, which is pretty impressively severe. Then we're going to talk about really the spectrum that happens. Now, not all of these, again, are appropriate in acute management, but a lot of times I find that where most of my help to a trauma surgeon or a military surgeon is really not in my skill, but in the way of thinking about things. Like, so for example, how do I figure out if there is a biliary injury? How do I figure out I've injured a hepatic artery or the hepatic artery is injured? What do I do now to figure out if there is perfusion or not? And sometimes surgery is not the answer. Sometimes it's ultrasound, it's imaging, it's IR, it's endoscopy. And those are the things that we tend to work with all the time that trauma and military may not work with all the time. So it's important to think about that. And then we'll talk about long-term outcomes. So just briefly on terminology, and I bring this up not that you all don't know this, but a lot of times when we look at this, we're looking at these terminology of like scales of energy, and I'm starting with the duodenum because actually the duodenum is the messiest one of all the HPB injuries and tends to be the most challenging to deal with for a few reasons. But nevertheless, if we look at the duodenum, a lot of times all of us focus on this and we ignore this. And what this is basically saying what is the injury severity score for these patients. And one thing you got to look at is this is out of 6. I mean, how quickly it raises up to 4s and 5s, and 6 is basically like it's more like a fatality, basically. And so it's amazing how severe these patients can get. And it's not because these things, it's because of a few reasons. One is when they're injured, they're hard to fix. But 2 is because they're rarely ever injured by themselves. So keep that in mind. Same thing with pancreas. It goes up very quickly. And again, this is not just to kind of understand how to terminologize it, but I wanted to make sure that we're all on the same page. Biliary, much easier to manage and less sick. In other words, you can get bad injuries and still be okay, which is good, and this is for liver. And so to add even more complexity to the whole thing is that the injuries themselves, I'm not talking about concomitant injuries now, I'm saying the isolated injuries. So a hepatic artery or portal vein injury or liver injury that is blunt is very different pathophysiology than penetrating, very different than blast. So that even makes it even more complicated in the sense of how to fix it. And then, an isolated right upper quadrant injury is very uncommon unless it's like a really lucky gunshot wound or something like that, if that's such a thing. But usually it's multi-abdomen things that happen, especially for blunt or blast. And then it's usually multi-cavity. So again, complicates it. And then there's the stable patient versus unstable patient. So I'm painting a picture of like, there's way too much going on here that is really very difficult to talk about this. But what's important is not to talk about the specific injury, but more to talk about the way we think about it. Now, For the specific injuries, there's really nice guidelines, and I honestly have to admit, I wasn't aware of these guidelines before I started preparing for this talk, and I've been reading them, and they're really well done. And there's multiple. So I really encourage you to get familiar with them, because a lot of what I was gonna say is on these. Like, for example, what do you do if you have a hepatic artery injury? And honestly, the answer is you could ligate it for multiple reasons. We'll talk about that. And so, but these guidelines actually really summarize a lot about that. But let's talk about the strategy, which I actually think is where it probably is most fun to talk about, and also where we can have a nice discussion about. So first of all, as a basic thing, is the rules for acute injury remain the same. Obviously, you're treating the patient, not the organ, although HPB surgeons tend to think themselves are special. The injury is an injury, the patient is the patient, there's nothing special about it. And so the idea here is you hemorrhage control, like we all know, limit or eliminate contamination as you can. And then, as an added bonus, you have to figure out, what am I gonna do with fluids? And I'm a big math and physics major, and remember, fluids is everything. Air is a fluid, and water is a fluid, and even solids are fluids. And so think of this as the spectrum of fluids, right? Because you're gonna deal with it, and you may not be dealing with it in the OR, but you're gonna be dealing with it a few hours later, and certainly for days to come. So figure out, what are you gonna do about pancreas juice? What are you gonna do about bile juice? What are you gonna do about enteric content? And that answer may simply be putting in drains. That's okay, but just have a plan for the fluids, which I think what gets most people in trouble. Then just remember that vascular injury, HPB organs are very vascular. Now this and the next one are connected. And I really encourage you to think about this, because I do think that this is where I've seen most pitfalls, right? If there's anything to learn from talking today here, I guess it's that this is where I've seen the pitfalls happen, is the sense that we as surgeons, especially when we're dealing with acute injuries, we feel like we have to confirm a doubt. And if we have a doubt, we have to confirm it. And we have to confirm it the best way we know how, which is by cold steel. And that's where I see that injuries become worse. And so, for example, if you know or have doubt because of an injury that your hepatic artery is out, okay? There is actually more harm done, and I've seen this multiple times, in actually trying to repair it or trying to confirm it than to confirm it with surgery than to leave it alone. It's so much easier and safer and less work and less threat to the patient to confirm it with a simple ultrasound to the liver with a duplex, as opposed to try to dissect it out. I've seen this even more pronounced in bile duct injuries. So where somebody has a bile duct injury, whether it's iatrogenic or trauma or theater, it doesn't matter, and there's an attempt to we've got to dissect it out to see, is it injured? What happens is often that you either devascularize the duct or you upgrade the injury. So the injury goes from an E1, which is a low transection injury right above the cystic duct, to an E3 or an E4, where where the hilum is injured as well. Even worse, if you have a concomitant biliovascular injury, so you have basically a right upper quadrant injury, which is actually the most common injury. You usually don't have bile duct isolated or vascular isolated from gunshot or blunt or blast. You usually have both artery and bile duct. What happens is we know the pathophysiology of concomitant biliary vascular injuries is that the injury will automatically, over the next 4 to 6 weeks, actually become a higher level injury. Meaning, if the injury is a D injury, which is a transactional bile duct injury, or an E1 injury, which is a full thickness bile duct injury but low, that, if you leave it alone, do nothing, will become an E3 by just retraction and ischemia due to whether it's basically cauterization or lack of blood flow or something like that. And so the answer then becomes why try to do anything in the acute setting besides put a drain, right? Because trying to dissect further just increases the injury, and repairing it is doomed to fail, right? Even in a non-trauma, non-blast setting, those situations, we know those that are concomitant biliary vascular injuries, repaired immediately, have a 60 to 70% chance of stricturing in less than 3 months. And so we don't recommend repairing those acutely at all. And those patients, we always drain and then just say, okay, you're just gonna have to deal with bile for 3 months. Now, sometimes that just basically means they're losing a lot of their bile or all their bile, and young people can handle that, but sometimes older people can't. And you have to start thinking creatively of things like refeeding and which is a little disgusting, but better than alternatives sometimes. But I guess what I'm trying to say is often the answer to a lot of HPB injuries is actually don't do anything. Now, that's not true for all injuries. Obviously, some injuries have to be repaired. There are a few of those. Like, so for example, injuries to portal vein, where you don't have blood flow, that's a problem. That actually needs to be repaired. Now, I've gotten to a point where basically I would just say just shunt it. So you take a portal vein and you just shunt it into the IVC. That's usually the best way to actually preserve the gut, and you don't upscale that injury by causing gut issues. And so shunting it, now you basically make the liver basically without portal vein flow, but that's a fixable injury, especially if you're in a place where you have to transfer a patient. So, and it's actually a very, it sounds, I'm not trying to be cavalier about it, but shunting a portal vein into the IVC is actually way simpler than trying to fix something in the hilum of the liver. So. And so, again, the idea here is to basically say to yourself in those settings, like, what do I need to confirm my doubt? And sometimes the answer to that is to start thinking of your friends, all right? So remember that what makes HPB an awesome field is that there is so many adjuncts. And yes, you have to be a good surgeon, but in general, you have to actually be you have to be able to think of what's the least invasive way for me to do something. I could tell you the number of times that I actually have dissected an artery to see if there's flow, or is very, very rare. At this point, it's all ultrasound, immunofluorescence, things like that. But obviously, you don't have that in the theater. So the key is transfer that out of the acute setting, treat the patient, and then we can actually look at that. And remember, I don't have a TV and I don't watch a lot of TV at all, but it's like the whole idea of like when you watch these cartoons sometimes, like for some reason, like all these superheroes, they always get matched with the situation that matches their superhero status. Like you don't get, the Hulk trying to fight some small little thing. They're always fighting like, it's almost like it's a coincidence that way. But the point being is, why try to do something that is so difficult to do surgically when it's so easy to do in IR? And why try to do something so difficult to do in IR when it's so easy to do by imaging or confirmed by imaging or endoscopy? And that's really where I think the matching of getting HPB consultation helps. Now, of course, these don't exist in the theater. And again, this is about the strategy of how you approach these. And you have to ask yourself, what do I have to do now? And what can you do later? And I think that's an important way to think about this. In general, when you actually look at GI, IR, HPB surgery, radiology, and time, sometimes time is all you need for things to figure out. There's a lot of things that we could talk about, but remember that in general, we actually in AHPBA published this book, which I'm just for disclosure, I'm a co-author, but I don't get any, there's no, I don't certainly have no financial, disclosures here. But the point is that it's a book that's written specifically about dilemmas in trauma with respect to HPB. And this is online, and you certainly can look at it each of these is a chapter, and it's basically written to correspond to a dilemma. So is there a role for non-operative management of right upper quadrant penetrating trauma? And so things like that. So it's basically written in a way that basically answers very specific HPB questions that a lot of trauma and military surgeons will have. And again, this is all online through the HPBA, and we've developed a lot of algorithms that basically kind of helps with, say, the amount of bleeding is a major or a minor, and just helps you kind of go through it, whether this is for liver, and we have multiple then for pancreas, for duodenum and pancreas. So this is head of the injury chapter, head of the pancreas chapter that basically talks about the salient points in understanding how do you drain a duodenum? How do you actually figure out you've got a blast injury to the pancreatic head, and you've got a shredded pylorus or antrum, which is actually unfortunately a common injury, and that's because the antrum and the pylorus tends to be more anterior. And so the idea is, how can you convert this in an acute setting to a manageable situation and then fix that later on? It talks about also delayed repairs as well. So with that, I just wanted to kind of summarize and say, the principles remain the same, certainly for all traumas. Understand that the key here is in an acute setting is to kind of control hemorrhage, control contamination, and figure out a path for the fluids to be taken care of. There are very few things that you have to fix right then and there. A lot of things are better dealt with afterwards when the patient is more stable. Understand that it's not all about just surgery, surgery, surgery. Often when you consult an HPV surgeon, the answer will not be them fixing it. It would be an interventional, a non-surgical solution, because we do have a lot of answers now for a lot of HPV, less invasive ways to figure that out. Obviously, always have a speed dial HPV surgeon, since they're usually a lot of fun to talk to. And then just remember that drainage is not a bad thing, and you drain them for a couple months and things get certainly much easier afterwards. And so with that, I'll stop. Really a pleasure to see you all here, and thank you for being part of the program.